Good morning, colleagues. Hi, I'm Jack Lewin. I know many of you from my former role as CEO of the American College of Cardiology and President and CEO of the Cardiovascular Research Foundation. Currently, I'm chairman of the board of the National Coalition on Healthcare in Washington and a member of the Scientific Advisory Board of Artria, who's sponsoring our breakfast today. We have two incredible speakers for this program on the future of cardiac imaging. Very, very qualified and wonderful people and good friends. First will be, our speaker will be Jagat Narula, who I'm sure many of you know. He's MD, PhD, and Master of American College of Cardiology, Professor of Medicine at Goodhart Chair at Mount Sinai, Director of their CV Imaging Program, Associate Dean there for Global Health at Icahn School of Medicine, formerly trained at Harvard MGH, was Professor of Medicine and Chief of Cardiology at Hahnemann, again at UCI with many distinctions, and now currently, obviously, at Sinai. He's unique in my mind because he has the distinction of both understanding the molecular and the subcellular pathology related to imaging, and he's used that knowledge to develop novel strategies for prevention of atherosclerosis, CV disease, and heart failure. He's editor-in-chief of JACC CV Imaging and World Heart Federation Global Heart, with numerous distinctions from the IOM and the National Academy of Sciences together. So Jagat, welcome, and my friend, and please take it away, Dr. Narula.
Thank you so much, Jack, for a very kind introduction, and it is so great to be with you again, and also so happy to share the podium with my dear friend, Ben Chow from Ottawa Heart Institute. So in the initial presentation, we would be discussing about the management of chronic stable coronary syndromes. What do we want to know and what can CT angiography tell us? So I have no disclosures. So here is the slide from ischemia study and then the post hoc analysis of ischemia on the right-hand side. So anatomic versus physiological significance of coronary stenosis as a basis of revascularization has remained a matter of contention. Although the earlier surgical studies had established intervention with the luminal stenosis exceeding 70%, subsequently availability of statins and other medical therapeutic agents prompted studies like Courage and Bari 2D, wherein the verdict was equally supportive of intervention and medical therapy. Although FAME family emphasized on the demonstration of functionally significant lesions, ischemia trial, shown here on the left-hand panel, concluded that revascularization and medical therapy were equivalent. But is there much more than what meets the eye? There was a significantly higher likelihood of spontaneous myocardial infarction in the medical therapy arm of the ischemia trial and a 50% reduction in spontaneous myocardial infarction in the revascularization arm as shown on the right-hand panel. So the important question is whether ischemia trial demonstrated failure of revascularization to reduce myocardial infarction or failure of ischemia testing to guide revascularization. Are we missing something more than the anatomy and physiology that we have been talking about? Something very similar becomes very evident from the extended 5-year follow-up of the FAME2 trial. Overall, there was no difference in the death as shown in the right upper panel, or myocardial infarction as shown in the left lower column, or even but there was a significant change or there was a significant benefit in terms of the urgent revascularization in the intervened arm. Regardless, as you would see that almost about 50% of the people with the abnormal FFR who were randomized to receive optimal medical therapy had outcomes very similar to revascularization in terms of death, myocardial infarction or need for revascularization. Even there was no difference in relief from angina. Therefore, all ischemic lesions do not require revascularization. And if so, how can we identify the FFR positive lesions that are safe to defer to optimal medical therapy? Or in other words, how to select those which indeed would be intervened upon? So in this very clever study from Samedi et al., they utilized the OMT arm of the FAME2 data. They used the invasive coronary angiograms to recreate three-dimensional geometric reconstructions of each patient's target coronary vessel lumen, as you can see here in the left panel and in the middle panel. They then identified patients with high coronary wall shear stress, as shown here, and those with the higher shear stress had worse prognosis, as you can see here in the line graph, and with a threshold cutoff point of 4.71 atmospheric. And on the right, you can see that the FFR plus wall shear stress did better than the FFR alone. And wall shear stress does allude to vulnerable plaques, as we very well know. It further emphasizes that we need some reliable, non-invasive means to identify the high-risk plaques. And then, could this prompt us to change the management paradigm? We should be able to, we used to mechanically revascularize all lesions greater than 70%, as in the left panel, and that is what we used to think. But subsequently, the FAME family of studies, as shown in the middle panel, recognized the importance of establishing the functional significance of these lesions. And almost 33% of the lesions were taken away. This bite only left 66% of the subjects who would need interventions. Then, should such cases which require intervention with the high shear stress, or could we non-invasively identify the plaques vulnerable to rupture? Would we be able to identify some more subjects which may truly be deferred? And as some of the data now coming from Dr. Motoyama's group suggests that only those cases who have the FFR, which is abnormal, and they have the high risk plaques, they are the only ones which do well with the revascularization. And those with the FFR abnormality, but still the high risk plaques, which may be not present, these cases could be safe to defer. And if so, can we safely defer these patients which have FFR abnormal and HRP negative, or cases which are HRP positive but normal FFR? Acute events are associated with distinct histopathologic characteristics, and such lesions or such plaques are referred to as high-risk plaques or plaque vulnerable to rupture, as is shown in the left-hand panel, where there is a post-mortem study of the coronary vasculature with the optical coherence tomography. Such plaques may often not even be stenotic, and the lipid collection may result in outward expansion first, as you can see here, something what is referred to as positive remodeling. These plaques are voluminous, as you can see here. They carry huge necrotic cores, as there are two necrotic cores in this lesion. And they have rather thin fibrous cap, as seen here, which are normally significantly inflamed. Rupture of these thin fibrous caps, as you can see in the angiogram, the OCT here with the coronary angiogram, which is associated with the STEMI in this particular case, that the rupture has indeed occurred. So rupture of these thin fibrous caps that expose the thrombogenic necrotic cores to the bloodstream, and the luminal clot results in coronary occlusion and hence myocardial infarction, unstable angina, or sudden death in these subjects. With Dr. Vermani, we analyzed close to about 300 vessels comprising about 100 ruptured plaques, 100 vulnerable, and 100 stable plaques, shown here by the red ruptured vulnerable as blue and green as the stable plaques. We wanted to define the histological features which would set these different types of plaques apart. The most important difference was in the fibrous cap thickness, as the ruptured caps, as you can see here, always had less than 55 micron thickness. And those which were vulnerable plaques, they had between 55 and 85 microns of the plaque thickness or fibrous cap thickness. Since the fibrous cap thickness assessment needs high resolution for imaging in living and can only be obtained through the invasive intravascular optical coherence tomography, we excluded this feature from our analyses in yet another recursive partitioning analysis or hierarchical importance of the morphological characteristics. Extent of the necrotic core and the extent of inflammation were two important determinants of high-risk plaques, which may both be amenable to the non-invasive imaging. We compared the CT angiography with Dr. Motoyama's group from Japan with the intravascular ultrasound imaging and demonstrated that the CT number or the Hounsfield units or Hounsfield unit densities of less than 30 corresponded to the intravascular ultrasound verified necrotic cores. 30 to 150 Hounsfield units corresponded to the fibrous plaques. With Dr. Motoyama, Dr. Ozaki, and Dr. Kondo, in the patients presenting with low-risk acute coronary events, we identified two features which were most representative of the high-risk plaques. One, the positive remodeling, as you can see here, shown by the yellow arrows, and the presence of low attenuation plaques of less than 30 Hounsfield unit densities, as shown here in the red arrows. There are the huge necrotic cores, and greater the size of the necrotic cores, greater the positive remodeling, more was the likelihood and earlier was the likelihood of having acute coronary syndromes. We called these plaques as two feature positive plaques, and those which were two feature negative plaques, they corresponded to the stable lesions. Upon follow-up of more than 3,000 patients with suspected coronary disease after CT angiography up to about 10 years, there was a significantly higher major adverse cardiac event rate in the patients with two feature positive plaques, as you can see here in the left-hand panel. The likelihood of an adverse event was about 10-fold higher than the plaques which did not have these two features over the follow-up of next 10 years. A second scan performed at an interval of 1 year was available in about 450 of these 3,000 subjects, and those who demonstrated plaque progression, as you can see here by the red line, or there was an increase in the necrotic core size, had a 35-fold higher likelihood of having an event as compared to those who did not enlarge or who did not progress over that period of 1 year, when plaque becomes stenotic, as well as you can see in the middle panel. The determinants of the high-risk plaques correlated with not only FFR as the extent of stenosis. It seems that both the luminal and positive remodeling of high-risk plaques are equally effective in preventing the dilatation at the lesional sites and hence the abnormal FFR. So the FFR would determine not only the stenotic lesion, but also possibility of a high-risk plaque, a huge high-risk plaque, which may yet not be luminally occlusive, but it might cause an abnormal FFR, and it may underlie those cases of abnormal FFR, but luminally non-stenotic cases, which may indeed result in acute events. The CT angiography can also demonstrate reduction in the necrotic core size upon lipid-lowering therapy. As you can see in this particular case, and the case that I brought is the one which indeed had only 25% luminal occlusion, but has a significant delta FFR at the mid-LAD lesion and was associated with a huge necrotic core and also with a significant positive remodeling. Upon a lipid-lowering therapy, I apologize for the lights going off. So upon the maximization of the statins and addition of the ezetimibe, after 6 months, you can clearly see that the luminal stenosis has not changed, but the necrotic core has significantly resolved and the positive remodeling has gone, and it is associated with almost normalization of the FFR. Computed tomography by itself or when accompanied by the PET imaging can be exploited for identification of plaque inflammation. PET imaging with positron labeled glucose presumably identifies activated macrophage inflammation in the or infiltration in the plaques over the roadmap created by CT imaging here. Since FDG is taken up by the myocardium as well, a high-fat and low-sugar diet preparation becomes necessary to obviate myocardial background for coronary imaging. In the initial study, the authors from Mass General Hospital used the stented patients, as you can see these stents here, stented patients for geographic localization of the plaques and hence the inflammation. Here you can see in the lower panel, you can see the spontaneous uptake in the bifurcation, which also represents the presence of inflammation, as so in the root of the aorta as well. In a very novel exposition, it became clear that the plaque inflammation and cytokine excess modulate integrity of the perivascular adipose tissue and adversely affect lipid phase. And this change can be measured as lower attenuation of the perivascular versus epicardial fat tissue. This excellent study coming from Dr. Antoniadis' group from Oxford tells us that the fat attenuation index assessment in participants of the Scott-Hart study provided an effective prognostic inflammation as shown in the right-hand panel. So, to summarize, eligibility for revascularization based on anatomic and physiologic significance of lesions has been debated and suggests possibility of a role played by plaque composition. Low attenuation plaque and positive remodeling best describe plaque vulnerability on CT angiography. Novel methods have suggested the feasibility of detection of plaque inflammation as well. FAME2 demonstrated that not all hemodynamically significant lesions require intervention, possibly true courage type patients. It is important to identify lesions that could be deferred to the optimal medical therapy. Prospective studies are needed to define the role of plaque pathology in management of chronic coronary syndromes, especially to define the vulnerable population in ischemia study. Our entire experience has been based on binary presence or absence of high-risk plaques, and better strategies need to be developed for quantitative plaque assessment, both at the lesion level as well as at vessel level. Maybe these will be the artificial intelligence techniques which would be of help. Thank you very much.
Thank you, Dr. Narula. That was a wonderful presentation. Incidentally, we will take some questions after both speakers have completed their presentation. It's now my pleasure to introduce Benjamin Chow, University of Ottawa, where he's the director of CV imaging across the whole spectrum of echo, CT, MRI, nuclear cardiology, PET, and so forth. He's co-director of cardiac radiology there. He leads the Ottawa Innovation Cluster on CV imaging, has numerous honors and contributions to clinical cardiology research and education in Canada and elsewhere. Member of the editorial board of JACC, has been affiliated with Mass General and Harvard and University of Michigan. He's truly a visionary and was the first Canadian cardiologist with advanced training in cardiac CT. So what a fitting person to remark to us today. And please take it over, Ben.
Great. Thanks very much for the kind introduction. And Dr. Narula is always a difficult act to follow, so I'll do my best. So these are my disclosures. So I think I don't need to remind the audience that CT now has been endorsed by multiple guidelines and meets Class 1 indication for investigating patients with chest pain. And now that it's become mainstream, we're actually faced with numerous challenges. But with challenges, there's opportunities. And so this is the outline of my discussion, is potentially talk about the challenges that's going to be associated with increasing volumes and the time that's required for processing images and interpreting images. Outside the scope of discussion, but equally important, is how we can refine patient selection, choosing the right patients for CT versus other imaging modalities, how we can optimize image acquisition, and then acknowledging the limitations of our current technology, but focus on the challenges of interpretation, and how we might be able to leverage technology to assist with stenosis assessment, plaque assessment, whether it be methods of assessment and quantification, and then how we can use and leverage technology to assess functional stenoses, or the functional aspects, hemodynamic aspects of each lesion. So as I mentioned earlier, it's an opportunity, and potentially question ourselves what the potential role of artificial intelligence is in terms of interpretation and assisting us with our clinical work. So volumes. So how are we going to accommodate with increasing volumes? So at my center, over 80% of CAD testing is still with non-CT modalities, whether it be SPECT, PET, invasive angiography, stress echo, treadmill testing. As there is a paradigm shift from these functional tests to CT, how are we going to adopt with the increasing demand and the higher volumes? The other thing is that the WHO has been monitoring global population, and we all are very much aware that the population is aging at a much faster rate. And by 2050, the over age 60 population will now be over 20%. So we, as clinicians, will need assistance with the higher demand. Now, in terms of accuracy and stenosis assessment, there's something that we very much have to recognize. So these are the multi-center trials that have been published. They're actually quite senior now. Accuracy, Core 64, the Mage Boom study out of Europe, and then the OMCAS, which was out of Canada. And the first thing you'll notice is that there is variability in sensitivity and specificity. Right, so with some studies at some institutions, they demonstrate higher sensitivity versus others may demonstrate higher specificity at the expense of a lower sensitivity. And this is our data that comes out of the OMCAS. So even within multi-center studies, we know that there's variability in accuracy. Within centers in each study, there's variability. And this is real-world data as centers were adopting this technology in the mid-2000s. And it shows that the sensitivity can vary from 50% to 93%. The other thing is the negative predictive value, which with CT is touted to be very high at some centers, could be as low as 42%. So why is this? Well, there's a couple of reasons. So people draw the line in the sand different ways. They'll choose different threshold for calling severe stenoses versus non-obstructive disease. And what we're very much cognizant of is as we increase volume and new centers adopt this modality, you can expect to see this type of variability at different centers. So we need assistance in maintaining diagnostic accuracy so we're not actually doing a disservice to the technology nor our patients. This is data from our group showing that, traditionally we use clinical risk scores to stratify patients into those who are higher risk, lower risk, and use that information to identify patients who might be candidates for statin therapy or lifestyle modification, et cetera. Highlighted in red are the two extremes. So on the horizontal along the x-axis, you'll see that there's individuals that actually have a 10-year Framingham risk score above 7.5%. Oops. And traditionally, these individuals, we would recommend statin therapy. But you'll see that there's a proportion of individuals where there's actually no evidence of plaque on CT. Conversely, there's another population along the y-axis where these individuals don't traditionally meet the recommendation for statin therapy. But you can identify, highlighted in the red box, is a population of individuals where we can actually visualize coronary atherosclerosis already. And so the important thing is we can use CT, the leveraging of the images and the ability to assess plaque to stratify individuals. This was a study that we just published recently that looked at the burden of plaque. And it's interesting to note that if you have 5 segments of plaque, that your long-term survival risk is similar to having single vessel disease. And really begs the question is, at what point do we start talking about statin therapy or medical therapy in individuals with plaque? And it's another potential metric for stratifying individuals. And it's really much highlighted with the Scott-Hart trial. So this is the 5-year outcome data from Scott-Hart. And to remind the audience, Scott-Hart demonstrated that in individuals that were randomized to CT and standard of care versus standard of care alone, that individuals had improved survival. There was no difference in revascularization rates. So it really begged the question, why would an imaging test improve survival? And it comes down to the data that they actually published in the appendix. And what in the supplemental appendix. And what they demonstrated that individuals that were diagnosed with coronary artery disease using CT, and coronary artery disease was defined by atherosclerosis plus or minus stenosis, had more intensive medical therapy. They had higher antiplatelet therapy, more statin use, more ARB, ACE inhibitor use, more beta blocker use. And the bottom line, or the thought is, that with intensive medical therapy in appropriately identified individuals improves outcome. So how good are we at imaging atherosclerosis? So this was a seminal paper by Alex Lieber in 2005, published in JACC. And he demonstrated that CT had the ability to image coronary atherosclerosis and correlated relatively well to IVUS. The one thing I will highlight is along the x-axis that using this technology, we miss still about 16% of individuals with plaque, or 16% of plaque. And why is this? Well, we are limited by the spatial resolution of our technology. This is a diagram representation of the different stages of atherosclerosis. And highlighted in the triangle on the bottom right-hand side is basically what CT can visualize. And as Dr. Narula was commenting, very large plaque we can probably visualize with CT. What we do have difficulty seeing is the early areas of plaque development and progression. And the reason is fibrous cap. Thick fibrous cap is still 0.065 millimeters, so 65 microns. If you actually look at the area of necrotic plaque, we're talking about a 1 by 1 millimeter lesion, which is actually at the spatial resolution of CT. So this is represented by 3 pixels on your screen. So you can imagine how we potentially miss smaller volumes of plaque. And this is just an example of the partial volume effect that we are exposed to in CT. So here's the left main, for example, so 4 millimeters in diameter, a little bit of plaque surrounding the left main. We overlay this vessel on these data elements, CT data elements, along with the plaque. And you can imagine here, although pixelated, the luminal truth reflects what truth is, the size of the lumen, and you can see this little gray area surrounding the lumen, which represents the non-calcified atherosclerosis. Now imagine, this works well in large vessels, but you can imagine if we start imaging small vessels, a 0.7 millimeter structure, 1 millimeter structure, basically that vessel represents 4 data elements, 2 by 2. And you can imagine the associated plaque next to it is going to be even smaller. So if this vessel lies perfectly on these 4 data elements, these 4 pixels, this square represents truth. What's the likelihood of that happening in a vessel that's tortuous? It becomes less likely. And you end up with very ill-defined contours and potentially our inability to identify coronary atherosclerosis or correctly identify them. Now, this next study was another study by Alex Lieber, who also, re-examined CT compared to IVUS. But the things that we take home from these are, number one, the plaque boundaries that we use for assessment is user-defined. It's extremely subjective. And in his study, he actually demonstrated the inter-observer variability was 37%. With the R-squared value of 0.69. So we, as a community, need some type of standardization. And Hook J. Chang actually tried to do this. He actually published this looking at different ways of assessing coronary atherosclerosis and quantifying plaque volume. And he looked at different ways of windowing. He used a dynamic range. He used a fixed window and level. He used a concept of no gap versus fixed gap, thinking that there's always going to be a tissue surrounding the lumen. And the take-home message really is the graph on the right-hand side. The graph highlights the fact that if you use different windows, different gaps, that you actually get different volumes, right? And one of the biggest things that Dr. Narula commented about is volume predicts outcome. So we got to get the volume correct. And another study actually showed that compared expert readers and non-expert readers for defining plaque. And highlighted on the bottom right-hand side are the contours of the same lesion by the expert and non-expert reader. And you can see the variability in the contour assessment. So some people will argue, well, this is expert versus non-expert, but I actually highlight the text on the left-hand side. It's actually the amount of time that it takes to do this measurement. So an expert reader, it took 34 minutes per vessel. The non-expert, 27 minutes. So if you actually want to analyze 3 vessels, you're talking about 1.5 hours, right? That's a lot of time for plaque volume assessment. And then Dr. Narula highlighted this a little bit earlier. This is a seminal paper from his group looking at the different plaque features. So not only do we want to look at the presence of plaque, not only do we want to quantify plaque, measure the volume, but now we actually have to identify features that predict adverse outcomes. So adverse outcome, low attenuation plaque, positive remodeling, spotty calcification, and we know that they all lead to adverse outcomes. So that's the plaque assessment. And then now we got to talk about hemodynamic assessment. So the FFR-CT has been shown to improve survival. It predicts FFR in the invasive cath lab. One of the potential limiting factors is that we're still shipping information, data, and images off-site for analysis, and there is a turnaround time. So what we're really missing is point-of-care FFR. So this was a study published many years ago, but it really shows the ability that we can take this, to the point of care, point of imaging, real-time data. So this study showed that they could actually assess using a regular desktop, and estimate FFR, and compared it to invasive FFR measurements with reasonably good results. Dr. Narula also highlighted there's a lot of things outside the coronaries that we don't appreciate. So PCAT, or pericoronary adipose tissue. And this study actually highlighted that individuals who have high pericoronary adipose tissue actually have abnormal sodium fluoride uptake, meaning that there's metabolic activity in that area, which probably also corresponds to increased FDG, increased plaque vulnerability. So there's things outside that we don't appreciate yet. And then this other study actually correlated the PCAT values to adverse outcomes such as acute MI. So again, there's other features within the pericardium that we perhaps aren't quantifying well. This is a study that we recently published, even looking at the attenuation of the myocardium. So we don't typically look at how bright or how dark the myocardium is. And this study actually highlights the fact that if you measure myocardial attenuation, you can potentially predict outcomes. And so this was a sub-study of the Vision CTA, a multi-center trial, where we actually looked at the attenuation of the myocardium post-op, post-non-cardiac surgery, and actually identified individuals who actually had abnormal attenuation values, actually were more likely to have post-operative events. And then as well, we did something similar using epicardial adipose tissue. And very similar to the PCAT thought or hypothesis, epicardial adipose tissue actually is a marker of coronary inflammation. So again, predicting outcome. So we go back. So, where's automation currently? So we look to the self-driving cars because it's in the news every day. So there's 6 levels of vehicle autonomy. Level 0, there's none. Level 1, hands-on, shared control. Level 2, hands off. Level 3, eyes off. Level 4, mind off. Level 5, steering wheel optional, right? So where are we? We're at level 0 with the potential to go to level 1 and potentially further down to the different levels as our technology improves. So lastly, I'll finish off with a few slides. So there is AI data suggesting that it can assist physicians with interpretation. So this is data from Dr. Idahid and Devetti's group, which is now in press, looking at how AI can measure calcium scores, right? So you throw in your data, AI gives you the answer. And the correlation was extremely good. And today at 10 o'clock, Dr. Idahid's going to present another paper of his looking at AI assessment of stenosis and plaque assessment, probably where we need to be going in the future. So I would invite individuals who are interested in the topic to attend. And then lastly, I won't speak too much about this. This is led by Dr. Narula, so he can speak to this, but this is how AI can potentially leverage information about the coronaries, patient characteristics, guesstimate FFR, and predict patient outcome. And then with that, I'll finish. Thanks very much.